warm welcome to Berlin.
Thank you.
I'm proud to introduce you, Mr. Jorge Esteves. Actually, you live in Dubai, and you're working there as an osteopathic. You come from Portugal, and you still have connection to the Institute of Piaget for research. Please tell us something about your work.
Okay, so I recently moved to Dubai, so exactly a year ago. I've lived in the UK for 17 years, so in those last 17 years, I worked largely as an academic. So I was for 10 years involved in the osteopathy degree programs at Oxford Brookes University. Then moved to the British School of Osteopathy in 2010 and stayed there until 2017, where I was the head of research, and where I taught and conducted research and so on. And during that, all that time, the research developed and completed my PhD and got involved in a number of projects. So, as I said, moved to Dubai last year for a new project. It's a sort of change a little bit in the kind of the hierarchy of things, in terms of my workload. So I flipped from more clinician side of my work with the academic work still having a role, but a more minimal one. So I'm involved also with an institution in Portugal, and that takes the form of scientific coordination of an undergraduate program at Piaget. So since last year, the education for osteopaths in Portugal needs to be done at higher education institutions, programs accredited by the government, and Piaget was one of the first institutions to have that accreditation. So a program that with colleagues we developed and put together and got through that process. So my involvement there is it's a sort of academic management of the program, and with teaching at least a couple of times a year, and research done with them, but also through my other kind of hat, which is with CAM Collaboration, which is a foundation based in Italy, and we have where I'm one of the directors. I sit on the board of trustees, and we have a number of projects. In one of them that has been developing very, very nicely over the last few years is the NEO project, which is neonatology project and neonatology and osteopathy, where we have around 15 hospitals in Italy, intensive care units for preterm infants, where osteopathy is now provided, and we conducting a number of research studies on that. So that there's a very good benefit to the babies and the families so far. So it has been a really exciting project also to be involved in. So that's a little bit about me and my work.
Yesterday I listened to your speech, and you said a very, very clever sentence. You said osteopathy is not only put the piece back or the tissue back into right position. Osteopathy is much more. It's complex. Please tell us about your philosophy.
It's something that's not unique to me of my practice, but I like seeing osteopathy as a form of health care that really addresses the individual as a whole. So we've just had a presentation a few minutes ago on the biopsychosocial model, and how you can put everything together and sort of making sense from an osteopathic perspective. And the conference we've talked a lot about models, philosophy, and so on. And personally, I don't sort of navigate through lots of models in my kind of approach. I look at the patient largely in three main kind of aspects. The biological side of things, the psychological side of things, and the social side of things. which are, is the biopsychosocial model, really, and try, the attention to maybe one aspect of sort of more biological or more psychological, will depend very much on the patient and on that particular day. So I think osteopathy has been criticized and continues being criticized, for example, for the lack of evidence in our interventions, and from a kind of evidence-based perspective, typically researchers or individuals in charge, individuals, for example, that develop clinical guidelines and so on, tend to look at the effectiveness of an intervention for a particular clinical condition, and I think sometimes osteopaths are at fault as well, because they kind of focus on, I treat back pain, I treat neck pain, I treat frozen shoulder, I treat cerebral palsy, I treat a number of things which sometimes there's no evidence whatsoever that actually things work, and that and then we are just under fire, because it's very easy for the most skeptic individuals to point the finger at and say, you can't make that claim because there's no evidence whatsoever that you do that. So, but I think if you really try to focus on the individual, suffering from back pain, or the individual suffering from the result of frozen shoulder or any other condition, either musculoskeletal or other, I think that's what brings the uniqueness of our intervention, and we have I think again we've heard on some of the talks people talking about a lot of the kind of the bottom up aspect, which is what the treatment does, and the physical contact, the technique, the sort of intervention, sort of at times largely focused on the body, and I think that is obviously an important part, because one has to think about we access the individual through a sensory landscape where it's the body, and of course the aspect of our physical contact, our touch, our techniques, they have a profound effect in terms of that physiology, for example, that neurocircuitry and so on. But we can't forget that that doesn't solve focusing entirely on that as a bottom-up approach, and sort of focusing sometimes too much on the biological aspects and not taking into account the whole kind of the whole package, and thinking that we are as humans, we are social animals, and sort of we have to take, for example, that into context. So asking, for example, patient, how is your pain affecting your life? It's not just the pain, where the pain is coming from and where it goes to, and a numerical number for it's 9 out of 10. But it could be a simple thing like my pain is affecting my relationship with my family, for example. Or my pain is affecting my ability to work, and
yes.
So of course we and with that can come issues of anxiety, depression. That's will be sort of there as maladaptive kind of behaviors, and will be there as really obstacles to full recovery. So if the osteopath, focusing simply on kind of treating the biological side of things, and popping things back in place, and forgets that, understanding the other side, and not claiming there are psychologists, not claiming they can do the intervention, but with simple things like sometimes reassuring the patient, actually your problem isn't that as serious as you think, or encouraging the patient, there has been a change, for example, in the tissues, and you now sort of, let's try to sort of move, let's try to exercise, let's change a little bit your lifestyle and your health and your attitudes to a number of things, including diet and so on. So those things have a profound, or can have a profound effect. And in that case, I think there's more hope for osteopathy to continue developing as a profession. So one very interesting phenomenon we observed in the last couple of years, I guess, is the rise of exercise as the new medicine. So everybody talks these days about exercise as the new medicine. So it's cheap, so everybody can do it. So available to everybody. And now, big talks about, are the GPs prescribing exercise? Are they competent to prescribe exercise? So that became a really important capability. And I've sort of last year I saw an interesting article on a blog by physiotherapists that in the UK, where they were claiming, the physiotherapists are ideally placed to deliver this form of care, exercise. And I thought, this is clever, because you're using something where clearly the evidence says, it works, okay? And you clearly say, we're trying to do that. And so nobody can claim that by saying, I can prescribe exercise, can help people in a number of conditions by, prescribing the exercise and so on, that I'm kind of stepping outside my boundaries and my intervention is not evidence-based. And perhaps that's something that osteopaths at times need to think about strategically in a clever way. And exercise is one of those things. We are also trying to prescribe exercise, to advise on exercise and so on.
Yes.
So, if that's part of of this sort of person-centered approach, and this plan of care includes really the sort of the encouragement of getting the patient to sort of, change sometimes their behaviors, their attitudes towards, for example, pain, disability, and encouraging them to get more active and so on. We are, at the end of the day, prescribing something that nobody can claim. There's no evidence in what to do. So it needs to move away, I think, from the idea that osteopathy is just about osteopathic manipulative treatment.
Right.
There's much more in it than I like calling osteopathic care because there's a package there.
Yeah.
You don't just manipulate the patient. You don't just do a cranial treatment. You don't just do a muscle energy.
You coach them.
You coach them, absolutely. So you are
in different ways.
Exactly. So you're a counselor. You are kind of you're in health promotion.
Yes.
So it's a sort of the different capabilities and different competencies of an osteopath. And I think, we need to kind of, as a profession, just think about that, because, that's preventative medicine. That is really something that is focused on the individual, is about promoting, health and so on. And as a result of that, I think, for example, if we treat chronic sufferers, chronic pain, for example, it's more likely that the patient get somewhere. So we help them managing the symptoms. We help them sort of get away from this idea that I'm going to focus on something wrong with your body and I'm going to try to cure your body and cure your pain, to an approach that is more about, there is pain, let's accept it. Let's think about how can we get
work together,
yes. Move to the next stage. Let's think about, what kind of strategies. And do it together, I think. And the patient focusing, for example, on improving their quality of life, you will be able to start ignoring some of the signals. I'm not sure about, for example, I like playing with my grandchildren, but I've got a knee arthritis. And I know if I'm going to bend and so on, it's going to be painful. So maybe I don't go out I don't take them to the park to play. But then if I don't do that, I miss sort of the contact with my grandchildren. And I'm getting older and I get the enjoyment of sort of playing with my grandchildren. It's good for my health.
Yes, I'm with you. Yeah.
So, I'm prepared to accept that, it's going to probably be a little bit more painful the day after, but I'm not going to give too much attention to it because I want to have fun and I want to enjoy life. And whilst managing, whilst understanding that actually that is not going to do any damage to my knee, that is going to be okay and it might not even hurt. So rather than those sort of focusing too much, yes, there is an arthritis, let's think about, the next stage, which could be, knee replacement. Let's, think about, that's something wrong here. Let's fix that. So I think collaboratively, you are kind of getting the patient sort of moving, like I presented, yesterday on work from one of my colleagues in the UK, from Oliver Thompson, They're sort of moving from this idea that you find in a lot of osteopaths, which are the treaters, are the guys in charge, to the sort of the ones that are more like the facilitators, the educators that empower people. Where in that sort of role, they are able to switch sometimes from, be more in charge and providing care, because, for example, there is a particular situation where, and it's not that much the patient can do, but I can do it, to the sort of then moving to, navigating through this sort of framework and say, you know what, I'm going to sort of, let it go and let's test the waters, let's see how it goes with this and come back, in, let's say, 2-3 weeks to see how you're doing. And so moving away from an idea that you've got in some parts of the profession where, it would be nice to see patients regularly as a kind of a preventative care, but what you then see is then a patient comes back to the clinic, 2 or 3 months afterwards, and you're going to find something wrong with the patient, and you treat the patient, and the patient may say, I've been okay, I've been pain-free, but you're going to find something wrong with the body, and kind of, you fix the body. And then so, okay, let's book an appointment for another 3 months. And that process goes on, which we criticize the chiropractors by doing it, but a lot of us do exactly the same thing. Is it a sort of a financial reward kind of element there? Yeah. Probably is. Pays the bills and so on. Is that the ideal kind of plan of care? Arguably, I don't think it is, because, if the patient is fine, I would sort of give the freedom to the patient to sort of to decide. If I start finding, I start getting some signals where maybe it would be a good idea to have a chat with my osteopath and sort of just see how it is, that's fine. But if I learn the tools and I can manage the problem on my own, I think we've done a great job. I think if the patients don't come back to see us for years, and then after a few years, and I've been great for the last 3 or 4 years, I think that's one of the most, absolutely, one of the most rewarding things. Or someone, comes and say, my friend or my, cousin or whatever told me that, to come and see you because, you solved, their problem, and, and they're fine now. So I think that's the great compliment, because, you've changed someone's life. Yeah. Okay, and you contributed to that. So it's not the sort of, fixing on, trying to fix the body, because, we don't think about our bodies. We are, our bodies enable us to be agents, to interact with other people, to operate.
They have to work, our bodies.
Exactly. Yeah. And so I we don't think about the head unless you've got a headache. You don't think about, I can't, you can't think about the shoulder unless the shoulder hurts. You do things. Okay? So when the whole thing kind of breaks down, you tend to fix on the body. Try to focus on the symptoms around the body, and you try to fix the body. And I think at times the approach, of course, works pretty well, and solve the problem, carry on, absolutely fine. Other times the problem doesn't, fixing the body doesn't solve the problem. You got this patient that then will end up sort of going around, seeing different practitioners, trying different approaches and so on, because a lot of people are focusing on treating the body rather than, thinking about the individual as a whole and say, maybe there's something I can do, something I can't, something that needs that sort of change in attitudes and beliefs and so on. So that's the way I see osteopathy, and really as a healthcare profession that does have its place in 21st century healthcare. Again, look at some osteopaths. Is this sort of debate? Who are you? Are you a healthcare professional or are you an osteopath? And some people see themselves as, no, I'm different. I'm an osteopath. I think we belong to the same community of professionals. We happen to be a speciality with their own sort of set of ideas, tools and so on, and that's fine. That's what it is. But you still kind of you still have a role in a much wider community. I think, and accepting that and having a kind of ability to communicate what you do and an ability to communicate what you do in a way that is plausible and other people can understand it will strengthen our position in the world. If we make big claims and we talk about things that don't make much sense, or the other healthcare professionals, for example, largely doctors, for example, don't understand, it's completely outside their sort of way of thinking, but which could be fine. But if it is something that is so strange, so weird, so poorly communicated, then there will be a knee-jerk reaction, say, yeah, no, it doesn't make any sense, you're out, basically, you don't belong to this group. So I think that is important. It's important, I think, in terms of survival, development of the profession, in terms of, getting profession to become more widely regulated throughout the world, where it's accepted by the state, by people, by insurers, by everybody. People have a role and a place in the system, rather than those individuals are just alternative thinkers and they're not safe, for example, because they don't do mainstream stuff. So I think that's the way I see things, and the way some of the tension, some of the difficulties we kind of have.
Yes. Great words, great sentences. I'm with you. Maybe to the end, one more question. What do you hope? What is your way of research? What is maybe the way you will find for experience? What is your personal profession for the future? Where do you see we can become more evidence? In which part of your work you hope for more evidence?
Personally, I'm in terms of research, I'm particularly interested in investigating processes rather than necessarily the effectiveness of an intervention, and that has reflected on the work I've done so far. So, for example, the work I did on clinical reasoning, and was kind of main aspect of my PhD, largely focused on palpation, but it was still a decision-making kind of study. So I'm particularly interested in exploring processes. What's going on when you make decisions? What's going on when you palpate? What sort of processes are happening, and so on. And so, it's something that always fascinated me. So it's something I like doing it, and that's and I've explored a few other things. For example, I'm particularly interested in exploring the way people who sort of chronic pain patients process their emotions, and we've done a couple of studies and published a couple of studies on that. And more recently, and so the work we starting at the moment with through the foundation in Italy, and sort of linked to Portugal as well, but also to a university, one of the universities in Liverpool, and their neuroscience department. We're interested in exploring this new form of touch, the C-tactile afferent, so the affective touch. We want to find out, what actually we think, our hypothesis, and we recently published an hypothesis paper on that. We think that a lot of what we do as osteopaths has to do with the stimulation of particular, sensory fibers that, in this case, do not go straight to the somatosensory cortex, but go to the insula and to frontal regions, and are associated with this sort of affective aspect of life, and we observe this in, not just with humans, but, for example, with other animals, from rodents to other primates, for example, how the mothers look after their babies and so on. Where do they, what kind of touch they do, where do they do that? So, for example, you typically find around the ears and the upper back and so on. And that has been now studied and sort of identified what sort of, what is the underpinning mechanism for it. We've got on the other side, the evidence that touch is quite important. For example, preterm babies with kangaroo care. So where, in particular in socially deprived environments, that now is a strong evidence. Several systematic reviews demonstrate that kangaroo care, so asking the parents to hold their babies skin-to-skin contact.
To poke them.
Yeah?
Yeah.
So that sort of skin-to-skin contact is going to help them to grow because of oxytocin and so on, but also through this sort of C-tactile mechanism also starts helping them develop as individuals. And we know that being deprived of touch, and from the early sort of animal studies in the 1950s where they did sort of studies, isolating little monkeys and giving them barbed wire kind of surrogate mothers and some sort of with cloth and so on. And they noticed that those little monkeys would prefer to go to the barbed wire kind of cloth kind of mother because, at least was a little bit more comfortable than just the sort of wire one. The other one was cold and it's not very comfortable and probably a little bit prickly and so on. So that kind of clearly, something is there that is interesting. Then we've observed with these studies with osteopathy in preterm infants that, so for example, some of the randomized controlled trials done in Italy show that a reduction in the length of stay in hospital, which is a very good outcome for the hospital because if you discharge the baby quicker and there's an increase in weight and so on, so a lot of markers kind of improve. That's a good outcome. So we noticed that works, and the treatment of these little infants, this sort of some 35 weeks, or it's largely a touch kind of based intervention because of course you're working with a system, maybe you're sort of working with a cranial sacral system and so on, but you are touching the baby. So we kind of observed that, and an interesting thing from our colleagues from the neuroscience world that are some of the experts in this sort of work on the C-tactile fibers is that's an interesting thing because those babies, there's no top down, there's no expectation of how does that feel, okay? Because if we touch, if we want to do the same thing on an adult, the adult, is conditioned, knows, if that's going to hurt, that's going to be pleasant, and before you do that, it's already sort of a top-down thing,
right.
A non-specific effect. Whereas those babies are the ideal kind of model to explore because, you stimulate what sort of physiological changes are you observing? Okay, so I'm, that's our research at the moment starting. Hopefully we'll get the studies. We are at the sort of design stage of a couple of the studies and going through ethics committee in Italy and so on to get the studies off the ground. Do some start doing basic stuff and move forward. So I'm particularly interested in that because I think a lot of part of the key to decodify the whole kind of osteopathic, manual treatment is something about, what we do when we contact, and several people talked about this osteopathic touch, it's not just the osteopathic touch is different from everybody else, but it's something about, what we do that actually even from a biopsychosocial perspective is likely to reassure the patient, is likely to make the patient feel more comfortable and so on, and actually is probably going to reduce some of the fear and so on. So it's important. So you're looking at that. I think it's important in terms of the overall research. I think it's important, and we need to have a large bulk of evidence for some clinical conditions. Unfortunately, although we don't treat the condition, it's important because if we don't have that, we sort of largely criticized. I think we need to be clever about the areas we sort of, decide to invest the time and the money and so on. So, for example, there's little to do on back pain. Plenty of work has been done on back pain. I think you found whatever has to be found for back pain. So, but there are other avenues. So again, some of the foundation work in Italy, we've got some promising work published on chronic migraines. And again, so what is, so works for chronic, so one of the studies published in 2015, we had, chronic migraine people receiving, under the care of one of the hospital neurology department in one of the hospitals in Italy, medicated, all of them medicated, some with 27, 28 days of pain per month, and the ones that received the osteopathic treatment together with medication, some of them reduced to 2 or 3 days per month, which is an incredible outcome. And compared to the ones that only received a non-specific kind of touch, or the ones that just stayed with medication, it was a sort of huge improvement. So that does not say that osteopathy alone works, but actually if the osteopathy somehow actually kind of potentiates the effect of the medication, then, and if you reduce from 27, 28 days a month to 2 or 3, you improve the quality of life of that person, in an incredible way. So there's more work to be done on that, and I think apart from sort of soft outcomes in sort of number of days and some soft measures, would be also important, maybe to do some sort of have some markers, inflammatory and so on. So and some neurological ones that actually there is sort of more clear evidence that actually there's a more objective kind of measurement. This kind of works. I think we need the clinical studies for sure. Okay. We can't just rely on animal models. It's great, for example, the work that is, for example, Lisa Hodge and colleagues do in Texas with the rats and so on. It's a really, really interesting work. Really kind of helps what we do, but we can't just say just because works on the rat it's going to work on a human. Okay.
Yeah.
And I don't think we can claim all the time, we have the evidence from this and that, because from a clinical perspective it's a completely different thing. So we have to kind of get better at that. I think a critical thing with this, and actually that's the work we're doing with the foundation, is to go outside osteopathy and start kind of a network with people from outside the profession. Yes. So get them, so for example, we had that with a neonatology. Get the neonatologists on board. When they see the work, they believe you. They kind of say, I want a minute. Once you've got a clinical director of the hospital, really interested in the whole project, you've done something good. Okay. When we've got people, for example, from neuroscience groups saying, we want that. We've done a lot of work. We want to do the clinical work now. We want to see if this works on the clinical populations as well. So we want to sort of not do research for the sake of doing research, but actually we want to do research on the benefit of people and patients and so on. So it's critical that we have, we develop strong kind of collaborations and so on. I think part of it then is how we communicate, what kind of language we use, what's the plausibility of our ideas, does it make sense or not. If it doesn't make any sense, they switch off. If it makes sense, most these individuals will be open and say, that's great, let's sit down, let's talk, let's see if we can, put something together, let's see if we can sort of find some funding. And because again, if there are sources of funding, the osteopath alone will not be able to do that. You need people with a track record that can kind of be part of your team and can sort of help open the doors. So I think that's a critical thing for the profession to move forward. So
in summary, we need clinical research.
Yes.
Yeah, and we need
some mechanism
the private work, the daily work.
Absolutely.
For a quality in life for our patients.
Absolutely. And I think with that sort of clinical work, it's important also, the osteopaths also gather data from their patients, for example, on satisfaction, for example, on soft outcomes, how many treatments did it take to improve this, pre and post, how do you feel, there actually any change, which simple questionnaires that people can complete at the beginning and at the end, where we start developing also a kind of a database of information that actually can be used to produce, for example, small case studies, that can be published, and sort of case series type of studies and so on, which is something that clinicians can do either alone or, maybe a group practice with 2 or 3 people in the same practice say, we'll do this, because that's also an important part of what we do. Yeah.
It was a marvelous, excited interview with you. And we should continue.
Okay.
Maybe later on by a beer.
Okay.
Thank you, Jorge.
That's all right. My pleasure.
Thank you. Pleasure.
Thank you very much.